Good morning, everybody. It's 10:30, so I'm about to start. This is very weird because I don't actually know if anybody is here, but if you could just type me a little message in the chat box to say, yes, we're here. I'm Jenny Douglas. I'm a senior... Okay, great. So it's lovely to know there are some people there and I'm not just speaking into ether. So I'm Jenny Douglas. I'm a senior lecturer in health promotion at the Open University, and I've been at the Open University for over some 20 years now. I am a director of the UK Public Health Register, and I've worked in public health for a very long time. Some of you may have known me from, I was Director of Health Promotion for Sandwell Health Authority from 1988 to 1996. And before that, I was District Health Promotion Manager for West Birmingham Health Authority. So I have quite a track record, I guess, in public health and within academic public health. I have also focused very much in my kind of academic and my practice career on the health needs of Black and minority ethnic communities. I've done that because of the inequalities that I knew then in the 80s about the health of Black and minority ethnic communities. So today I'm going to be talking about why COVID is having a much greater impact on Black and minority ethnic communities. So so I've just noticed one of the comments. I didn't know that Open University has been around for 20 years. We've been around for over 40 years. So I am now going to try and share my screen. So hopefully you should be able to see my screen now. So I'm going to talk hopefully for about 10 to 15 minutes, and then you will have some time to ask some questions. And hopefully... I can see my screen, but it doesn't seem to be moving on. Oh, right, okay. So, as I say, I'm going to talk about COVID-19 and Black and minority ethnic communities. And my kind of premise is that COVID-19 has actually shone a light on existing long-standing health inequalities. So the health inequalities that Black and minority ethnic communities experience, they have experienced for decades, and that COVID-19 has just come and shone a light on it. And with the kind of increasing knowledge about the disparities in relation to COVID and its impact on Black and minority ethnic communities, this kind of came in tandem with the Black Lives Matter movement and with, well, I can say it now because there's been a verdict on the police officer, and with the unlawful killing of George Floyd last year. And so the two things have almost gone in parallel. So you can't actually think about COVID-19 without thinking about Black Lives Matter. Here in the UK, Black and minority ethnic communities make up 14% of the population, but they made up 34% of critically ill COVID sufferers, and Black and minority ethnic people were twice as likely to die from COVID-19 than their white counterparts. When we look at the statistics in terms of Black and minority ethnic doctors, both GPs and hospital doctors, the majority who died were from Black and minority ethnic communities, many of them coming from overseas. So what are the reasons for this? The reasons are very complex and intersectional. And by intersectional, I mean that our identities in terms of our race, gender, age, ability, disability, sexuality, all intersect. And they all actually impact on different aspects of our identity. So they are not separate entities. and they interact, and they continue to interact and change all the time. And so there have been different discussions, different explanations put forward in terms of why Black and minority ethnic communities are having the greatest impact from COVID-19. Now, some people have suggested that it's socio-demographic characteristics, that it may be age, geography, wealth, prior health, pre-existing comorbidities. Some people have suggested that it's biological explanations, for example, vitamin D deficiency. And some people have suggested that it may be due to structural racism. My own position on this is that it's due to structural racism, so I will say that right at the outset, and that structural racism is actually manifested in a number of different ways. And when I say structural racism and systemic racism, I'm not talking about the day-to-day racism that people experience, although that does have its impact. I'm really talking about how organisations within their policies and practices actually discriminate against Black and minority ethnic communities. And despite the report that we had last week, the Sewell report, which sort of suggested that structural racism doesn't exist, there are so many reports that have demonstrated structural racism within our education service, within our police service, within universities, within health and social care. And it's this structural racism that has been long-standing that has its impact on Black and minority ethnic communities. I discount, although the biological explanations may have an impact, so vitamin D deficiency may have an impact. What I want us to move away from is a notion that race is genetic or biological. Race is a social construction. It doesn't have any biological basis. So the Public Health England report, Beyond the Data, that was produced last year, which tried to understand the impact of COVID on Black and minority ethnic groups, argued that the disparities in both the risk and outcomes of COVID-19 show that there was an association in relation to belonging to some ethnic groups, and also the likelihood of testing positive and dying with COVID was seen in particular ethnic groups, and that those ethnic groups were Black ethnic groups. And so we saw a higher rate in both Black females and Black males, and we saw a lower rate in white ethnic groups, white females and white males. In both groups, we saw that the impact of COVID was actually higher in males. So an analysis of looking at people who survived from COVID showed that when you accounted for differences in terms of sex, age, deprivation and region, people who were Bangladeshi had twice the risk of death compared to people of white British ethnicity. And people of Chinese, Indian, Pakistani, other Asian, Caribbean and other Black ethnicity had between 10 and 50% higher risk of death when compared to white British. So we can see from the data that the death rates for COVID were much higher for Black and Asian ethnic groups when compared to white ethnic groups. So one of the kind of key factors in that report and in other kind of subsequent reports is that COVID has actually exacerbated long-standing inequalities, long-standing health inequalities, and that Black and minority ethnic communities are also at greater risk of exposure to and acquisition of COVID-19. And this is due to a number of, as I say, intersecting factors. Many Black and minority ethnic people are in occupations that were at the front line, people-facing occupations, so they were at greater risk of exposure. They were also living in areas where there was a higher population density, that people were more likely to be using public transports, and that people's household composition and housing conditions also exacerbated their increased risk. In that, there were many households that were multi-generational, and that also in those multi-generational households, it is actually much harder if you have to isolate. Excuse me. So we can see that there's a much higher proportion of people from Black and minority ethnic communities who are key workers and who are in occupations that place them at higher risk of social contact and the risk of being exposed to people who are infected by COVID-19. And many of us will remember that the kind of African woman who worked on London transport, who somebody actually spit at, and she died later on. Now that is still ongoing. We don't know whether or not that the reason she died was because she was deliberately infected with COVID. But, that links into the discussion about racism and discrimination, that discrimination will actually cause a greater kind of impact of COVID. Just looking at the time. Have I come to the end of my 20 minutes? Oh, well. Anyhow, in terms of workplace bullying, that people who are Black and minority ethnic people working in the workplace may also not be in an environment where they can ask their managers to address some of their concerns. And we heard a lot about this in the earlier days of COVID in relation to the lack of PPI. So also, once infected, many of the pre-existing health conditions that Black and minority ethnic people have may be exacerbated. And those pre-existing health conditions are often due to their socio-economic position, and also to the impact of racism and discrimination. Black and minority ethnic people are in particular jobs, are more likely to be living in poverty because of the discrimination they face in getting certain jobs or in living in certain housing. So we can't actually unpick any of those factors. So for many Black and minority ethnic communities who are living in poorer areas, there's a higher risk also of chronic diseases and multiple long-term conditions, and that these conditions occur at an early age. And we also can't discount the role of severe mental illness as a risk factor. So I've tried in a short amount of time to talk about the kind of interrelationship between racism, discrimination, stigma, fear, and trust. And for many Black and minority ethnic people, racism and discrimination is a root cause that affects their health, their exposure to risk, and the disease progression. Racial discrimination affects people's life chances and the stress associated with being discriminated against based on race and ethnicity affects people's mental health and physical health. And issues of stigma associated with COVID-19 may also impact negatively on health-seeking behaviour. So if people feel a stigma from COVID-19, they are less likely to present for treatment and care, and therefore more likely to get diagnosed later. So we do need to consider some of the factors such as diet, vitamin D, and housing. We also need to consider the long-term impacts of COVID-19 on Black and minority ethnic communities. These are likely to be long-term and severe and to have lasting health and wellbeing impacts. We're starting to hear much more now about long COVID, and it may be that that Black and minority ethnic people are more likely to experience long COVID for a whole range of reasons. You know, if we go back to employment, a lot of Black and minority ethnic people, as well as fearing the stigma associated with COVID, may also be worried about their employment, their jobs. That in the jobs in which they are employed, they are actually very worried about being diagnosed with COVID because they need to work. So there are a whole range of factors which actually impact on the reasons why Black and minority ethnic communities are at greater risk of COVID. I just wanted quickly to say that, as I said, race is not biological. It's a social construct. But racism has biological consequences. And I would argue that that the impact of COVID is one of those biological consequences. We can see, you know, in terms of seeing the long-term and long-standing inequalities in health, not recently, we have known for a long time that Black women are 5 times more likely to die than white women from complications in pregnancy and in the period following childbirth. Now, this isn't something new. This is something that has existed for decades. And in many ways, it's kind of like the tip of the iceberg, which demonstrates that racial inequalities exist. And then, you know, they're not kind of a figment of our imagination. They are real, they exist, and they impact on life and death. In relation to COVID and Black and minority ethnic people, Black and minority ethnic women, that in a study last year, in women who were admitted to hospital in pregnancy, 25% of those women were Asian and 22% were Black. I'm just going to wrap up very quickly. So we can see that there is an unequal impact of COVID and Black and minority ethnic communities, and it can be explained by a number of factors ranging from social and economic inequalities, racism, discrimination, stigma, occupational risk, long-standing health inequalities from a number of conditions, and that we need to kind of address all of those long-standing conditions in the future. There are a number of references in reports. Some of you may have seen the excellent BBC documentary by David Harewood on Is COVID Killing People of Colour? It's still on BBC Catch Up, so it's really important that you take a look at that. We at the OU produced a very short video, and the link is here, on race, COVID and me. And the Public Health England report, Beyond the Data, is very useful to read. So I will stop sharing now. And I'm sorry that we've got such a short time left for questions and answers. Oh, right. So, I hope you can all see me and we're back. So I've got a question here. What role do you think practitioners can play in ensuring COVID care is more accessible and trustworthy for Black and minority ethnic communities? I think, oh great, you can see and hear me. I think that public health practitioners have a huge role to play. I'm currently involved in a research project at Oxford, which is looking at the diverse experiences of COVID and of diverse communities who have not been hospitalised. And one of the things that people have raised is information, public health information. And I think that, you know, one of the areas that we're not getting right is getting public health information out to all of our communities on COVID, what it is, and the ways of actually trying to reduce exposure to COVID, making sure that you're tested for COVID. And unfortunately, I think that we are going to see widening inequalities in relation to vaccination. We need to make sure that that we get information to a range of communities about vaccination, and that, you know, and that information is relevant to those communities and is authentic information. I think there's a lot of misinformation in relation to vaccination. And, you know, I've talked about the kind of lack of trust that many Black and minority ethnic people have in relation to health services because of the poor experience that they have had in the past of health services. And again, this is well documented. It's well documented that Black and minority ethnic people experience racism and discrimination within the health service, unfortunately. And so I think as public health practitioners, there's a lot that we can do in terms of raising awareness of information. There's also a lot that we can do as public health practitioners about raising issues when we see discrimination operating, that we actually kind of, you know, we can raise it. Where we can see systemic racism operating, that we raise it. I can see a lot of information on the chat, and I think I've gone over by 2 minutes. So I'm not sure what I'm supposed to do now. But anyhow, perhaps I know that I'm doing another workshop at 11 o'clock, so we can continue the discussion. I'm just reading from the chat because I can't see all of the chat, but so Angela Ellen says, in Newcastle, we have a public health practitioner who works with BAME communities via local networks and has worked well to share COVID messages, links to guidance, testing and vaccination. And I think that we need to do a lot more of that. So I think, as I kind of said at the beginning, that in a way, COVID has really just shone a light on existing health inequalities. And we as public health practitioners, we are the ones at the front of that vanguard. We really need to be making sure that we are addressing health inequalities in whatever way that we can. Okay, so we have a short break. Okay, then, and we start again at 11. So thank you very much, everybody, for attending. And well, we have a break now, and I will see the next group. Take very good care.